All right. Hello, everyone. Good evening. Good afternoon. My name is Dylan Rivera. I'm the Senior Digital Marketing Manager at Aerolase, and we want to thank you all for joining this evening. We have a special presentation lined up for you today, where we will be focusing on what dermatology gets wrong around lasers and how to safely treat every Fitzpatrick skin type. Also joining me is Udelke Williamson, National Director of Accounts and Dermatology. Udelke, how you doing tonight?
Hi, everybody. Not good evening, good afternoon, good morning. I don't know where we are. So, yes.
And to that point, everyone, please let us know where you're tuning in from. Please write in the chat box. We will be answering throughout the presentation. And for any questions, please direct those in the Q&A section. We will be leaving 20 to 15 minutes at the end of the presentation to answer all of those questions. And with that down, let's bring out our featured speakers, Dr. Corey Hartman and Dr. Michelle Henry.
Hi everyone.
Hello.
Hey, doctors, how you doing tonight?
Doing well. We see lots of friends here in the chat box. We're excited.
Oh, y'all are in there. I love it. From all over the place.
Yeah.
All around the country, California, Florida, Toronto, I think
Jamaica.
Canada.
Oh,
Jamaica,
Mississippi.
Michigan. Ooh, okay.
Awesome. So to our audience, we do have a really special presentation tonight where we're going to be talking about all things energy delivery and sort of what differentiates different technologies, and definitely hearing from Dr. Hartman, Dr. Henry's personal experiences throughout their careers using different devices and treating, again, all Fitzpatrick skin types. So we definitely want to make sure we have time at the end to answer everyone's questions. So why don't we get started with the presentation, and we will see you at the end for the live Q&A. All right.
Excellent.
Thank you.
Awesome. I guess
You won't let me leave.
Sure.
Go ahead, sorry.
You can stay.
Yep.
Should we start with a little intro, Corey?
Sure. You go first. Ladies first.
Oh, thank you. Thank you, ever the gentleman. So hi, everyone. I see some old friends in the chat box and some new friends. So for those that I don't know, my name is Michelle Henry. I'm a dermatologist. I'm based in Manhattan, New York, where my practice, I do everything from general derm to Mohs surgery, but we're heavily procedural and heavily aesthetic, and a big portion of that are lasers. We have a research group where we're doing lots of laser trials, and a big part of our laser trials are really to extend established trials so that we can really get more skin of color in those trials so we can get better data. So this is right up my alley. Longtime Aerolase fan, and I'm excited to talk to you guys about the technology today.
And I am Corey Hartman. I am a dermatologist in Birmingham, Alabama, also in private practice at a practice called Skin Wellness Dermatology, where we practice comprehensive dermatology. I have a personal focus on pigment, acne, injectables, and all laser devices that we can safely use to treat a variety of skin types and indications and conditions. So I am so happy to be here tonight on behalf of Aerolase with my really good friend, Dr. Michelle Henry. And we are going to kind of dispel some myths, iron out some truths, talk about some things that are true, and hopefully give you a better sense of what differentiates Aerolase from other laser devices out there.
Yeah. And this is a great way to start. So when we talk about lasers, I think one of the things I hear the most in my office from patients coming in from other practices is that lasers aren't for skin of color. They told me there were 0 lasers that could work on me. And I think with my consultations, that's a lot that I see. And I think this, a lot of the fear that has been infused into the space around skin of color, it's still delayed in patients understanding that technology has changed. Technology has caught up to our increasingly more diverse patient population. And so I'm sure that's a lot of what you see too, Corey.
Yeah, it's the same. Patients come in and they have preconceived notions about what they can and cannot have. For better or for worse, social media has sort of helped in a way because it's gotten the word out about things that patients need to really look out for and questions that they need to ask when they're getting to know a new provider or a doctor or laser technician or whoever. but it also can put people in the position where they don't really know what to believe because they hear, conflicting information. And it's good to be able to kind of iron some of that out so they can know what's safe and what's not. Because like you said, Michelle, technology has come a long way. I finished residency now 20 years ago, and that was kind of the rule back then about how, you had to avoid a lot of heat and dark skin. You had to, we had a bunch of lasers, but most of them were absolutely not to be used on dark skin. And that's not the case anymore.
Yeah, I agree. And even though a lot of patients are still afraid, I would say social media, just like you said, it's good and bad. Most of it is like edutainment, right? So it has to be provocative to get patients interested, but they are starting to really grasp some key concepts. So I'm having patients come in and say, do you have a 1064 laser? So if you are looking to treat that population, you must have it, and it is the gold standard for patients of color. And we'll talk a little bit more about, the pulse duration and the things that really makes Aerolase stand out in the market to really improve that safety profile for these patients. But they're going to come in, they know more than they used to know. They're going to ask for the appropriate devices. They're going to ask for the appropriate wavelength. And we really want you guys to be prepared and ready to serve them and get safe, predictable, reproducible outcomes.
100%. So yeah, in the training, I think just like in all things, people learn one thing and then they are resistant to accepting new information or learning about new technologies that come out. And to be honest, once we get into our silos, if you've learned something a long time ago and you're not at those meetings where they're talking about these things in particular, it might be hard to get that information. But there are a lot of devices out there like the Aerolase that have come a long way and can treat a variety of patients. So, we always were taught that you just go lower, you go slower, you take your time with skin of color. But the problem with that is you turn the laser down so low and you're not really going to get an effect at all.
Yeah. Exactly. And so like we have here, if you're above Fitzpatrick 3, cut your fluence in half. Like, what does that even mean? Like, is that based in science, right? Like, where did we get this? Like, just cut it in half. And so not only,
Literally made it up.
yeah, literally made it up. So not only are patients suffering from like having whatever disfiguring pigment they have, now it's financial abuse,
I was
because
about to say,
we're not doing
exactly.
anything to make it work. Yeah.
Yeah, if you're cutting it in half, you're making it take twice as long, but I bet you're not giving them a discount on those treatments. Right?
Exactly. So how far does this tax go, So we want to make sure that we're giving patients something that can work for them. And now we're in a place where we can do that with confidence. And really, that's what they're expecting. Again, social media is both good and bad. So they're hearing the bad. Those patients that are deep researchers, they've gone out there, they've seen the devices that can work, they've seen the before and afters, and they're going to, want that. And so really their expectations have risen. And so we have to make sure that we can meet those expectations.
Absolutely. You treat one patient well, though, and you're going to have a bunch of them telling all their friends. Okay, I think we're both trying to. Sorry.
Yeah.
Okay. So, yeah, this is just a really good sort of cartoon on the right that gives an idea of how the melanocyte is activated when the skin is heated too much with other devices. And you see that all that does is stimulate that melanocyte to create more and more pigment. So you're typically going to be trying to treat pigment with these devices. And if you heat up the skin too much, you're going to actually end up giving them more of the adverse effect that they came in to treat. So pigmentary changes can occur. Of course, that thermal injury can lead them to have pain, blistering, a bunch of discomfort that nobody's signing up for. And then we don't want their texture to be uneven. We don't want to cause any atrophy. We don't want their skin to get thicker for sure. So these are the complications that, are not user mistakes necessarily, but they're just mismatches in how we choose the devices for certain patients.
Exactly. And so, when we're doing lasers and skin of color or at all, it really is just like we're in the business of heat management, thermal management. So if we call, laser surgery is based on the theory of selective photothermolysis. So we're going to find the target, we're going to use the wavelength that is best absorbed by that target. We're going to give that target enough energy that we can destroy the target, but not cause enough collateral damage. And when you're looking at darker skin types, we have those melanocytes and all of those melanosomes that are packed everywhere. And the second we produce enough inflammation to allow all of those inflammatory markers to come out, they're stimulating those melanosomes. We're getting that activation, and we're getting hyperpigmentation. And that heat can play a role in that. We also know that mechanical trauma can play a role in that. That's why you see things like friction melanosis, right? So we know that we have to be exceedingly careful with how we treat darker skin types. And as we talk more about the Aerolase is more gentle in many ways. We have a wavelength that's going to go beyond the epidermal melanin. We have a pulse duration that's going to be fast enough that we don't get collateral damage. And we also are not getting such high peak energy that we're causing so much mechanical trauma that we're still going to get inflammation. And so we'll dive into that a little bit more as we go through the slides. All right.
So yeah, this is just a good, show of the devices that are currently on the market and some of the ways that the pigment can be affected if these devices are used incorrectly, and how they're using overtreatment on a regular basis. So photomechanical injury, like Dr. Henry was talking about, causes these melanosomes to absorb a lot of energy, which disrupts the epidermis and causes hyperpigmentation. And that causes changes in the skin and those side effects that we talked about that are not very fun to go through.
Exactly. Yeah. So, when we look at this, we just talked a little bit about like the pulse duration, the picosecond device. I do use that a lot. However, when it does create that photomechanical energy, it can be quite harsh. It's less heat, so it makes it safer, but it's still, in certain patients that are particularly sensitive, any sort of shock to those cells can cause hyperpigmentation. Q-switched, prior was, what we would use a lot in patients of color. We know we'd get epidermal damage. That was just something we'd have to deal with. But those high peak pressures, it's like throwing a firecracker at the skin, Yeah, you're going to get rid of some of the bad pigment, but you're also going to disrupt a lot of the good pigment you want to get. So now we've moved far beyond that. When we look at the long pulse lasers, like the long pulse Nd:YAG, diodes, alexandrite, IPL, we should just strike from the list. We really should not be using IPL in skin of color at all. We know that IPL is just like incoherent light. It's just many different wavelengths, right? And we filter it out in ways that we feel like it's safe, but it's not the level of precision that we can use to really be surgical in skin of color. Also, alexandrite is a little too short. The diode is also uncomfortable. The Nd:YAG long pulse is safer, but again, when we're using those long pulse devices, we're getting more heat, and we're in the business of heat management. So we're looking for ways to access our target and again manage heat. We can go on to
next one.
Perfect.
Yeah, that Q-switch device that was our gold standard for tattoo management and pigment prior to devices like Aerolase and even picosecond technologies. The pigment gets confused a lot. The laser's not really smart enough to tell the difference between the pigment that is supposed to stay and the pigment that is not. The melanin, that pigment is the same. The way that the variable that helps to control the risk is how you distribute the energy and how you control the heat, not just the fact that there's melanin that's present. You just have to know how to manage that melanin more effectively. All of these devices that we use really invoke an injury to the skin, and it's how we control that injury that determines our outcome.
Yeah. I absolutely, I always tell like the residents here, I'm like older school lasers can't tell the difference between pigment and pathology. They're just confused. And so the way I sometimes describe it to the residents is it's kind of like a Mission Impossible sort of thing. That laser has to like sneak around the other cells, sneak around that epidermal melanin, and really deposit itself gently at our target in such a way that we destroy it. And we can do that now. We just had to get a lot smarter. And so, again, we're always managing heat. We're always making sure that we are thinking about the depth and the position of our melanin. With darker skin types, sometimes we're treating epidermal melanin, sometimes we're treating dermal melanin, and we have to really be mindful of that in how we choose devices, how we choose our energy, how we choose our pulse duration. So really, it's an active process. And when we talked about that before, is that really understanding these principles, it's so important because, we don't use the same exact setting for every patient, but we need to understand the range. We need to understand, what we're trying to treat, and always thinking about managing that heat and focusing on that target in every patient.
And understanding that the Fitzpatrick is sort of an old school suggestion. It's the best thing that we have, but we know that it's not the end all be all. And you have to have a little more nuance when you're talking to your patients and deciding about lasers, because there's many different heritages and ethnicities lying beneath that skin. So don't be afraid to ask and really get to the bottom of it, because you don't want to find out because a bad outcome occurred.
Yeah, exactly. Like, talk about heritage, like what we call, black, for instance, could be everything from a type 2 to a type 6, right? So don't
Exactly.
be afraid to talk about that, because even those patients that may look like they have lighter skin, I always say those are the patients that have hidden melanin. Like sometimes a type
Mhm.
3 can be harder to treat than a type 5, that they'll have really dark hair, really light skin. That can be really difficult. So talk about ethnicity. Look for those markers. Like we often look at the lines on the palms. If we see more pigment there, we know that's a patient that's more likely to have hyperpigmentation. So feeling really comfortable is not only going to give your patient confidence, but it's going to give you really important data to make the right decisions for your patients. So we'll go next slide.
Next.
Um, so what provoked this? I think it's, us, physicians
Right.
like us,
Yeah.
using these devices. And
Yeah, we didn't have what we needed before, and I'm so thankful that there are companies that are dedicated to
Mhm.
studying how our skin behaves and how, the skin of patients with more melanin is different and the unique needs. So
Yeah.
creating devices that have unique settings, that have offer different ways to treat is just really important so that we can avoid undertreatment. We can give our patients more consistent results and still it still treat them in a way that helps them with what they came in with. Otherwise, we have this fear-based setting that just causes more PIH, and it's not the skin that's the problem, it's the heat. So the
Mhm.
device is really what needs to be responsible for managing that along with the person who's doing it, and not putting that necessarily on the patient, sort of not blaming them, but putting them in a position where they feel like they are at some disadvantage just for being who they are, that they will be able to have any treatment for the problem that they're coming with for.
Exactly. And hats off again to Aerolase. A lot of these laser companies are kind of like retrofitting their products to patients of color, when really, patients of color were thought of at the onset. When I first
Mhm.
started working with Aerolase, a lot of it was to really get diverse photos, really to get diverse patients involved so we could really fine tune the setting. So then when we're out here telling these patients it works for you, we're not just saying like, maybe it might work. Find the right doctor. That Aerolase knows, has an idea of the settings that we could use, has a deep wealth of information and data on this patient population, and the wide range of treatments that these patients can benefit for. And so that definitely has changed the conversations we've had around lasers and skin of color. Next slide. Um, I'll do this one since she is my patient. So this was one of my first patients, and so I just mentioned like the many different indications. So the 1064 laser is great, especially with the 650 microsecond pulse width for targeting pigment. But the 1064 laser is also uh, phototoxic to P. acnes, and so it helps to kill the bacteria that contributes to acne. So this is a great device for patients who have acne and hyperpigmentation. If you have patients of color, acne and hyperpigmentation go hand in hand. So if you're treating one, you're treating the other. So this is really great. This is a patient who had used lots of other treatments. Frankly, she just had like topical fatigue. She was tired of using all of her topicals. She didn't want to use oral medications. And so this is just a really great treatment for those patients. They don't require numbing, so it's easy. I do these treatments oftentimes, every, depending on how severe the patient is, every 2 weeks to every 4 weeks. They don't require numbing. They can come in right before work. There's no downtime. It's easy in and out. I even have a lot of patients let's say women that are pregnant with acne. I have a lot of their OBs now. I always get it cleared that are okay as long as they're not using numbing cream to use this on their acne during pregnancy. So it really gives me an additional tool for patients who, don't want to use oral medication or just averse to topicals and just want something different. So this is a patient who's very, very happy, still a patient of mine. We still do treatments occasionally. This is probably, 10 plus years she's been my patient. But I really enjoy this device for this indication.
Right. Yeah. So the fact that this device can treat active acne, I think, is a huge feather in the cap. Because, like Dr. Henry said a couple times already, it's the inflammation. You all know this. It's the inflammation that drives the pigment. How many times have you had a patient come in concerned about the pigment, and you have to sort of like convince them that they even have acne? They just have maybe breakouts or zits, but they don't have acne. And that's, we have to tie that together. So the fact that we can kill two birds with one stone and get started on the treatment for the after result as well really makes people happy that they can do that. So this is another patient with, they're calling it moderate inflammatory acne. I may even venture to call this severe acne. This looks like it's going to scar. It looks like it's going to do more than just cause color changes. And we want to be aggressive with this treatment. And this is a way that you can do that, get a handle on the inflammation and prevent the pigmentation changes and also the changes in the textural surface. So the pigment treating PIH is a treatment complication. Not a patient condition, but it's definitely something that drives people in, and it concerns them more than the acne. So again, if you can get this kind of result with no downtime, treatments that are not super frequent, but effective so that patients can start to see improvement relatively quickly, I think that helps everybody involved to get them on board and in line with the program.
For sure. I would definitely say that one was severe. So this is a patient, some acne, but it looks like she had a little bit more hyperpigmentation here. Had tried some topicals and chemical peels, and they really wanted to speed up her clearance and improve her overall tone. I do think she has a little bit of makeup on here, but I think overall you can see that even through that, you could see significant improvement here. And I could even see improvement with her texture, and this, this sort of result is really kind of like an average result, This is something that we kind of consistently get in this patient population for something that's not painful, that's easy to use in your office, for a device that doesn't have disposable. So it's really kind of seamless to add into your workflow. Even if you're someone who has, more medical patients, because you don't have numbing, it's, patients are in and out. And how many patients have acne and hyperpigmentation and with skin of color? All of them.
It's a top driver.
Yeah. Right. So this is kind of I would say this is a very like standard reproducible result that is easy to expect and promise to your patients.
Somebody in the chat's asking how many treatment sessions for each case. And I know on average, we usually recommend 6 treatments, 4 to 6 treatments, depending upon, if there's any hair involved or not. But, and they're, like Dr. Henry said, spaced 2 to 4 weeks apart.
Yeah, exact same, 4 to 6 treatments too.
All right. So switching gears to melasma, another favorite of ours to treat. We know that melasma doesn't really have a cure and will require some sort of maintenance for the life of the patient. So it's nice to be able to incorporate a treatment that can get us results like this without excessive heat, that can even out the skin tone and set an expectation for patients that, we can knock this down, but there's going to be some sort of maintenance involved. I have patients who pop in, every 6 months for a treatment just to keep the melasma at bay. We see the settings down here. The energy is a little bit higher because you're also treating and targeting the dermal vascularity, not just the melanin. The patient's skin tone improved significantly as well. You can see her skin is less dull than it was before, and of course, certainly more even. So, of course, with melasma, it's never monotherapy with the laser. You're going to do some topicals at home as well, but that's just part of the life for a patient with melasma. They're just happy to have results.
Exactly. Um, I see we have a question here that do you vary from settings provided? Do you cool off skin between passes? Um, I think the settings that we've seen here are pretty fair, starting out in darker skin types, I do start like 14 to 18. I can go up to 21 in some of those patients, starting a little bit higher here. And you know what? You're always checking in with your patient, but I
Mhm.
rarely have to cool off. You're moving over the face. So by
Yeah.
the time I've gotten down to the chin, because again, it's not holding that much heat. It's that short pulse duration. We're not getting that much collateral damage. I can go back up to the zygoma region and they're already cool. So you really don't have to take a tremendous amount of time if you're moving over the entire face. You don't want to keep pulsing in one location, but if you're continuing to move, you really don't have to have separate time to cool down.
Yeah, and patients are all different, obviously, but it's very rare that patients report significant discomfort with the Aerolase, the Neoderm.
Okay, so facial erythema. So this is actually really exciting for me too because it allows us to treat erythema not only in lighter skin types like this patient, which is like a skin type 2 to 3, but also in darker skin types. Because 1064 also has an effect on vasculature. While
Mhm.
it's not going to be as aggressive as a pulse dye laser, which is nice because you're not going, you're at lower risk for you're not going to get purpura and all those things you might do if you're going to treat with a pulse dye laser. But you're still addressing it in a softer, more gradual way. And it also treats inflammation. So if you can treat vasculature, you can treat inflammation because what happens when you're inflamed, you get those, leaky vessels that are putting out all of those inflammatory markers. If we can treat those vessels, we're getting some vasoconstriction. And so we're reducing the blood vessels, the redness, and the inflammation. And so that's why this is going to work in something like rosacea. We also use it on patients that have eczema because it has that both vascular and anti-inflammatory component. In my patients after filler, I treat them with this. Darker skin patients who have bruises, I'll treat them with the Aerolase, and we get great results. So this is, again, another kind of reproducible case, and kind of just shows the variety of patients that we can treat with the device.
Yes. After I see another question, back to acne. After the 6 treatments, what can the patient expect? Continuous treatments are needed at what interval? It really depends on the patient, how
Mhm.
much hyperpigmentation they're dealing with afterward. If they're really solely, controlling the acne, obviously, I know I put everybody on some sort of retinol as
Mhm.
a first line treatment. So, you might just need the Aerolase every quarter, maybe twice a year to kind of keep the acne in check. Once you have good, firm control of the acne. But the regimen, I think, drives more than the device after we get out of the relatively clear phase or
Yeah.
into the relatively clear phase.
Yeah. Yeah, I agree. It's very patient dependent, and what we're doing with the treatment is we're clearing them up and hopefully giving them kind of a durable response. So many months of reduced acne with touch ups from time to time. The next question was, are you removing hair as well as targeting acne? So the settings are a little bit different. When
Mm.
we're treating hair, it's a little bit higher, and we don't necessarily have to go that high for acne. So I personally usually separate those treatments, or I'll do one setting for the acne, and then I'll come back, change my settings, and if I have like a targeted area like a chin, I can do it on the same day, but the settings are a little bit different. All right, next slide.
All right. So the common theme with the Neoderm and just in general, and the secret, honestly, to the success of Aerolase is that 650 microsecond pulse width, because that delivers the energy in a small little snippet, and that's going to lead to efficacy, but also safety. Remember, it's not just how high the energy goes, it's the control of that thermal energy and how you deliver it to the source, to the target, that will determine whether or not your treatment is predictable or not, and whether or not it was successful or not. The variable that actually controls the risk is not how much melanin is in there, but again, that pulse duration, and that 650 microsecond pulse duration is specifically unique to the Aerolase devices. So yes, it's the Fitzpatrick skin types loosely will kind of give you a guide to where to start. But again, you still have to use all your wits and keep in mind when you're choosing your settings, what you're targeting, what you're trying to treat, what the patient's been through before. But they're all comers that can be treated with this laser. You don't have to be specific and eliminate certain populations, because it's not going to be safe to treat.
Yeah. I've definitely treated the richest, deepest, most mahogany skin with success and comfort. So you really can treat every patient. Next slide.
Close.
Okay.
Yes. And this is just, more on that. Go ahead, Michelle.
No, I was just going to say exactly as you said. We want to be able to get to our target with that 1064. So we're bypassing epidermal melanin, right? So we're bypassing the melanin that would confuse us from pathology. And then we're surgically emitting that energy in such a way that we're just destroying the target. And not causing enough collateral damage to get hyperpigmentation. If we give more energy, we're going to get more heat, more collateral damage. We're going to get epidermal trauma. And so this is really, again, that mission impossible, sneaking around that epidermal melanin, all those other structures, and really just gently depositing that energy exactly where we want it with reduced thermal diffusion. And so it's doing exactly what we want in a very safe manner.
A very targeted approach.
Exactly. Someone asked a question, thoughts on cold therapy devices post-treatment. There's really no reason for cryotherapy, and again, it's just so comfortable that you really don't need it, Would it cancel the effects of Aerolase? No, not unless it's so cold that you're giving like frostbite or something. So no, it would not do that. And then in terms of the time that you are using to service your patient, honestly, 15 minutes, 10, 15 minutes. It's very, very quick. And once that patient is kind of used to it, they're in the room, staff cleans them up, you do the laser, they're out, they're off, they're back to work. It's a very, very fast procedure. Next,
there's another question about settings for hair removal. I would say like starting at about 21.
Yeah, for sure. And that depends on how large the hair is,
right, density, all that.
Exactly.
Caliber.
Exactly. Next slide.
A pathology-driven skin-inclusive clinical treatment algorithm. So this is just a little guideline to kind of keep you in line with how to treat patients. You look at the patient, you identify what the pathology is that you're trying to treat. You consider their Fitzpatrick skin type. Look at the the lifestyle of the patient, the timeline of the patient, and then try to get some specific treatment endpoints that will reduce the inflammatory triggers from outside, as far as sun exposure, et cetera. And can this be monitored, adjusted, and repeated? So just if you're kind of a beginner, this is a good sort of paradigm to follow to deciding on how you're going to approach each individual patient.
Yeah, exactly. Next slide. I see. Okay, I see another question here about when you say you use the Aerolase after filler for bruising, is there any risk of it affecting the filler negatively? No, not at all. Oftentimes we're placing filler much deeper then where the Aerolase will penetrate. So, we're doing it like subcutaneous. It's not really dermal, although we call them dermal fillers, right? So we're going much deeper. So I'm not really worried about that at all. And we'll do it even the next day. And, again, this is like surgical thermal management. So we don't have to worry about the temperature going so high that it would disrupt the filler either. And actually, I would say if anything, it will help, because if it's reducing the inflammation, helping us control swelling, helping us controlling bruising, it's going to help you get better outcomes with your filler and make those outcomes a little bit more predictable too.
Great point.
Yeah. So which slide are we on now? Traditional lasers versus Aerolase technology. So yes, again, Q switched. It's like throwing a firecracker at the skin. IPL is just, all sorts of wavelengths of light, including those in the 500 nanometer wavelength, which is like loves melanin and will just burn that epidermal melanin. So IPL is super dangerous. Long pulsed, again, we're going to get, it may penetrate, but we're going to get like a long pulse, all that heat, lots of collateral damage. So all of those things are going to put us at a somewhat higher risk of having hyperpigmentation. And with the Aerolase, again, it is that surgical, very specific precision placement of the energy to damage that target. So minimal heat, minimal inflammation. Because of these safety parameters, we can use it on many different Fitzpatrick types, and we can do serial treatments because of the gentle nature of it without being concerned about overall damage to the skin. Next slide.
All right. So it's always important to try to have really specific and strict protocols so that you ensure that you're doing things in a safe manner. That way there's less guesswork involved. We're looking for that immediate mild erythema that goes away after a few hours. You don't really want to see any epidermal disruptions, so no blistering, no rippling, just a little bit of erythema, not even a lot of edema necessarily. Treatment spacing, again, if you're looking for treatment in acne and inflammatory conditions, maybe every 2 weeks, and then space that out for conditions that depend more on vascular structures like melasma. When you're managing expectations, always value cumulative improvement over a dramatic injury. Again, remember, these are controlled injuries and we want to maintain control. So you can always learn from the previous treatment. And if you are in doubt, go lower. And then post-treatment, it depends on patients. We don't always do cold compresses immediately. Sometimes we'll put like a mask or something if the patient needs something to help calm them down. Gentle cleansers are very important. We don't want to disrupt that epidermal, that barrier for any reason after a treatment. We want that to stay as intact as possible. And then always resume SPF immediately, because once that skin has been treated with any sort of thermal treatment, it's going to be more vulnerable to pigmentary changes and the damages of the ultraviolet light. Next slide.
I see we have another few questions here. What's the best setting for melasma Fitz 4? So again, you have to see the patient, but I usually do a lower range, more similar to what I'm doing for my acne patients, than like that 21 and maybe above that we may do for hair, because you also want to think about the size of your target, right? So when we're treating melasma, we're working on those teeny tiny organelles, right? So we don't need massive, massive energy to treat that teeny tiny organelle. So I use lower energies for melasma. And then melasma is just so persnickety and fussy. Even with a safe technology, you don't want to use anything that's aggressive, because, heat alone, even, more mechanical type trauma can flare melasma. So we want to be really careful with that. Now, why working with confined laser energy matters. So clinically consistent protocols and defined endpoints are really important, because again, we want to have standardization. We want our patients to trust that Our results are, something that are reproducible. It reduces their anxiety when they come in. They know they can predict the level of pain, the length of the procedure, the kind of interval improvement that they may see between each treatment. So really having consistent protocols are really important. Understanding your endpoints is critically important, so this is not the kind of procedure, even when you have a device that's safer, where you can kind of like fall asleep or like think about something else, stay completely engaged, always looking at the skin, always looking at the level of erythema that you might see on these patients. But what's great about this is, again, there's a broader candidate pool. And because still that misinformation is out there that patients of color can't have these treatments, once patients learn that, hey, you can have them, you can have them safely, and you can have them at this office, it is really, you're having their friends, their coworkers, the person they met on Instagram, the person they met on the subway. If you're in New York, people really sing your praises because there's so much fear. Once they find that safe person who can give them what they want, they tell everyone. And it really can grow your practice significantly.
For sure. The patients love to share great results, and they will send everybody they know to you for the same exact treatment because, we live and breathe this. But the fact that there are devices that are safe for patients, everybody doesn't know that. They're looking for this information and they're going out there and getting fed all kinds of stuff that may or may not be true. So it will definitely help to broaden your candidate pool, and it'll be a easy device to onboard and get running quickly in your practice. I know whenever you get a new device, if you're like me, you wonder, how long is it going to take to get this cranked up? How long is it going to take to get it into the routine? And with the Aerolase, it was like seamless. I mean, I feel like we've always had it. We've had it for a few years now, but I can't remember life before the Aerolase.
Yeah, no, for sure. Excellent. Next slide. So as we've been saying, we'll drive it home. It's laser safety isn't about like, avoiding a population of patients. It's about understanding that patient, understanding their skin, and really understanding the technology, and making sure that they are paired appropriately. So understanding the physics of the lasers, understanding melanin, and where we want to place this beam, what we're targeting, and so it really does become a great opportunity, for a patient population that believes they have nothing. You're giving hope, you're giving fantastic results, you're giving safe, reproducible results. You're augmenting your practice, again, whether it's medical or aesthetic. And then there are many other treatments that we can do. I see someone ask here about your eczema settings. Again, my eczema settings are a little bit lower. They're not going to be as high as my hair removal settings. It's about reducing that inflammation, treating those blood vessels gently to reduce the inflammation. So they're going to be a little bit lower. And of course, it depends from patient to patient. It does change a little bit. So one more question we had here, I may have missed this, but can this laser be used on deep skin tones for anti-aging and to treat wrinkles? Yes, you can. A big part of how we do age is the fact that we're getting dyspigmentation, so it helps with that. But also, if you subscribe to the inflammaging, whatever we can do to reduce inflammation is going to help to support our collagen. It's going to help to fight against that constant and steady collagen degradation. And so with time, you will see improvement in skin tone and texture.
I think we saw that in some of the patients that we presented here tonight, too. You can see that just overall improvement in their texture and tone. And that really speaks to the fact that the inflammation is not destroying the collagen.
Mm-hmm. For sure.
Welcome back, Udelki.
Oh,
Other
I can sit here and listen to all of you, to you two all night. I am in love with both of you. You know this. There are obviously more questions, but before we go even into those questions, thank you, Dr. Henry and Dr. Hartman, my sister and brother. So, so we need to be careful with Corey. With that said, there are still a couple of more questions if you guys don't mind answering them. I see, is purging common after treatment? Either one of you would be great.
Yeah, that's not something that patients complain about.
Yeah.
Certainly after some chemical peels and after maybe some resurfacing lasers, but the
Mhm.
Aerolase is one, I think, because it, can the P. acnes is a target. It can treat acne. We really don't see that. I haven't seen it. Michelle, have you?
No, I've not either. And maybe because it is anti-inflammatory, we're not seeing it as much. But yeah, I've not seen that in any of my patients actually either.
Okay. I love this question because I get this from everybody.
Oh, wait, I
What
missed
is
this one. Is this the
what is the
combining one?
no, this
We
is what
skipped
is
that
the
one too.
number one or the top few things you love about using Aerolase when compared to other lasers on the market that you may see everywhere.
What do I like about it? Well, I like the fact that honestly, everybody doesn't have one. I mean, Yaki probably doesn't like that, but I like
No,
the fact that
Udoki doesn't
it
like
makes our
that.
practice it makes our practice stand out because once patients do find out that we have it, they have flocked, and I mean all sorts of patients, not
Mhm.
one type of patient,
Mhm.
because it does so many things and it's so easy to have done to you.
Yeah.
So, my favorite thing about the Aerolase is that I can treat as aggressively as I feel like I need to. I can delegate this to my staff, and I feel confident that we're going to be delivering safe treatments. That's the most important thing. Just with so many issues with lasers out there, it's nice to know that you have the safety on your side.
Yeah. Yeah, I agree. The safety profile is great. The fact that you could treat many indications, that's great. On the same patient, I could treat, hyperpigmentation, hair loss, a little inflammation here. The fact that there aren't any disposables is great. So I have a patient that just has, a few
Love
pimples.
that.
They want me to just like touch them up. It's like I can do this, high end treatment. It doesn't cost me a lot in terms of, incremental cost. And patients really, really love that. I use it as a way to spoil patients sometimes because the incremental cost is low. So I have a patient that they got a ton of filler. They want to get one more. All right. Well, if you get one more, we'll give you an Aerolase for X half off, or when you come in, we'll do a treatment. It's just a really great way to grow your practice in many ways. So you can do so many things with it, and it gives me a lot of flexibility to play around and grow my practice in creative ways.
We did
Do
miss
you
that
guys?
question about combination
Oh
therapy,
yeah,
Delphi.
yeah. Skip that
I
one.
wanted
Yes,
to
we
answer
did.
that one
We
just
did.
because it's so
Please
unique.
do.
Well,
Please
yeah,
do.
because you were one of the first ones that kind of put that in my mind, specifically combining the Aerolase with VIPO. And I know there's a partnership between the companies, and it may be counterintuitive to you if you're not familiar with both. VIPO can be a little bit more of an aggressive laser, especially in patients with skin of color because it does have a little TCA. But that combination packs a mean punch. You are still delivering safe, effective treatments. Patients get to their treatment goals that much quicker. And it really just sets you apart because it gives patients the impression and the knowledge that you know how to make things happen for them in ways that others don't.
Mhm. Yeah, for
That's
sure.
with peels. How about microneedling or anything else? Do you guys combo with anything else?
I mean, you could, because it is, again, we are not having that much thermal energy buildup. So we definitely do. I've paired it in the past with microneedling with my patients. When I'm doing that, especially if I'm doing something like microneedling and radio frequency, I actually do cool patients down in between. If I'm doing something like just mechanical microneedling, I typically don't. But if I pair it more with the RF and to help with the pigment component. But yeah, patients do well with that. If I'm doing it with microneedling RF, I do it if I'm doing it on the same day, I do it a month apart. But it's also great to have patients come in, 2 weeks later to do their Aerolase. 2 weeks later they do their RF. So it kind of depends on the patient, but it is safe to do at the same time.
Do you pre-treat skin with any specific skincare prior to the Aerolase?
I don't
Um,
necessarily think of it as a pre-treat. Do you do that, Michelle?
I don't, because a lot of it is like, historically we would pre-treat patients with hydroquinone, but if they're not treating hyperpigmentation, now they're mad because we've lightened their skin and there's so much
Yeah.
resistance to that anyway. So I don't really pre-treat, they're on good skincare.
Right.
But I'm not doing anything also because I do think the safety profile is so great that, and we've both been doing it a long time, that I'm not as concerned about that. But I don't routinely pre-treat with hydroquinone. If I was going to do something, I think good skincare is a great idea. Stopping any products that might any active ingredients that might make things unpredictable, you could do. But as to pre-treat with something like hydroquinone, I don't typically do that either.
Is there a specific condition out of all the indications that we have that you guys believe we're the best at? Or is there several favorites? I get this question all the time. What do you do the best? And I'm like, that's hard to narrow down. So
yeah, I mean, it really is hard, and it's because some of these are so intertwined. I mean, we touched on this already, but it's unique that it can treat active acne. So I think you do that very well. There are some other devices on the market that work in a different way to effectively, allegedly treat acne, but they're very painful. They don't really deliver. So I think that that's huge, but also just the fact that you treat more than one thing at one time, two conditions that are so intimately connected, like pigment and acne. I mean, I talked about this before. It's hard to detangle the two and explain to patients the importance of treating both. So it eliminates that whole conversation for me a lot, because I just say, just use this laser and it'll get everything. And I know confidently that I'm not wasting their money treating hyperpigmentation when the acne is being ignored.
Yeah, I absolutely agree. It was my first love for acne for sure. And as Dr. Hartman said, there are many other devices, but they're uncomfortable.
Mhm.
They're uncomfortable, and sometimes the expectations of how those devices have been positioned are not always met, and that makes it harder. And because it's uncomfortable, it's a lot easier to say, let's do one more Aerolase than it is to say, let's do one more of this very painful device. So it is definitely, I think, a fantastic device for acne. I think it shines in many areas, but I think that's one of the areas where I think it's really fantastic.
Thank you. Hey, Dill, did I miss anything?
We have a couple more questions, so I can share with the stage. Jamie asks, do you pre-treat skin with any specific skincare prior to the laser?
I think we answered that one just now.
Yeah.
Yeah. And
That
yeah,
one's
I think that depends on the patient.
gotcha.
Yeah.
All right, so here's a kind of like an add-on. How do you like stacking treatments with microneedling same day? Any tips on neck tightening?
I will
Well,
use them the same day depending on the kind of device I'm using. I do kind of cool patients down in between. Tips on neck tightening.
is that a separate question? That seems unrelated.
Yeah.
Seems unrelated to me too.
All right. All right, next one. How can I help with HS?
Well, again, inflammation, and it helps with, if any of the hair is impacting the HS and flaring it up, I think it's a good adjunct treatment for that. I don't know if it was first line. Obviously, it's not indicated, but it can certainly help to calm the inflammation, reduce bacterial load, and treat any hair that's trapped underneath that may be exacerbating the problem.
Yeah, for sure.
We do have some studies for the person who did ask that question running currently for HS. So as soon as those things are published, you guys will have it. Anything else, Dylan?
We did kind of answer this one, but just maybe for a refresher, what's the amount of time you're servicing your client for each service on a normal basis?
Yeah, really short. I'd say 15 minutes. And part of the 15 minutes is just, the niceties, hi, nice, how's holiday?
Sure.
But the procedure really is like, 5 or 10 minutes.
Awesome. So I do believe that caps all of our questions for the night. Dittoing what Udelki said, Dr. Hartman, thank you so much for all of your insight and taking the time tonight to speak to our audience. As we can see here, it's very educational, and I know our audience is very appreciative as well. So, Ducky, is there anything you'd like to say before we sign off?
No, just thank you. For the audience, we will be doing these monthly. Next month, we'll be talking about the resurfacing, ablation, and things of that sort. So that will be the topic. We haven't had a title just yet. And we do know that Dr. Cheryl Burgess will be the speaker or the lecturer. But that will be next month. And the month after that, we'll be talking about I believe, autoimmune conditions. So very conversational, world-renowned dermatologists at the caliber of Dr. Henry and Dr. Hartman. And again, just very conversational, and so that everybody can feel comfortable and ask all the questions that they want to ask. We will have this recording sent out to everybody that's registered. Dr. Hartman and Dr. Henry, we will send them to you as well. And hopefully I will see you both soon. Than later.
Yes.
On that note, thank you again, and have a good evening to everyone.
Bye, guys.
Everyone. Bye-bye.
Bye, everyone.